first specimen is need to adjust the focus first. Okay. The first specimen is a Pura effusion specimen. So on low power, we see like a very scattered single cell throughout the smear. On higher power, this cell is like a singly or dispersed, but with very prominent nucleolus. If you compare to the adjacent size of the normal lymphocyte, this is gigantic. This is very big. And most of the cells show eccentric, like nuclear pattern, and with a little bit of cytoplasm with a foamy like texture. Some might probably look like there's mucin inside. So this is compatible with Séguin cell carcinoma. So these poorly differentiated carcinoma can occur primarily as primary lung adenocarcinoma. However, the patient does have the past history of gastric cancer. So this is a gastric cancer with Pura involvement already across the diaphragm to the thoracic cavity. And you see in this smear, almost, I would say 90% of the cells are tumor cells. So the patient had a very large disease burden. Okay, so this is positive for adenocarcinoma. If you take a look at the cell block preparation, the cytomorphology is very similar. So you see like a large nuclear, prominent nucleolus, and a vesicular chromatin pattern. And most of the cells are showing these small cluster or single cell, and with a signaling cell morphology. So the next specimen is from a patient of past history of lung adenocarcinoma. And this is her Pura effusion specimen. So in this specimen, we see very scattered but tight, like a three-dimensional cluster. So it is not easy to see through this cluster because it is very three-dimensional. So we will need to look for a like more flattened area. So here you see the cell does arrange in a tight glandular pattern. The nuclear size and shape is different from each other. There is a distinct nucleolus over here as well. So this is compatible with metastatic adenocarcinoma. The patient has the past history of lung adeno, and we have confirmed these with TTF1 stain in our prior Pura effusion specimen. In these cell block preparation, they were only very scattered adenocarcinoma, like a few clusters. So there's one over here with similar morphology. So this is compatible with lung adenocarcinoma. So the next specimen is kind of rare and a bit difficult. This is a 26-year-old female who had the past history of renal cell carcinoma. So she is very young. So in this age, for patients with cancer, it is not uncommon that you will see the patient might have some genetic cancer syndrome. In this ascites specimen, there were only very scattered and poorly preserved cells. The cell does show a TPI, and you can see cherry red nucleolus over here. The staining is not optimal because we have severe drying artifact. So overall, based on only a few clusters of these, we can say we definitely have some atypical cells, and the degree of a TPR is exceeding just reactive changes. But it is kind of difficult for us to definitely call these metastatic renal cell carcinoma because we don't have enough material at the cell block preparation, and these would be the very first confirmation of ascites metastasis to the peritoneum cavity. So we would rather call these suspicious. So we have scan suspicious cell, and the clinical history is renal cell carcinoma. I think the morphology is compatible, but as you can see, the size of nucleus is not particularly very big. Usually for the renal cell carcinoma, we will have quite some bubbly cytoplasm, particularly for the clear cell carcinoma. So we only have scan material, and we don't have enough material for ancillary confirmation, so we will call this suspicious. But just based on these few clusters of cells, I think this is highly suspicious for metastatic renal cell carcinoma. The CT scan does show some nodularity in the pleura surface, so it is likely, but because of scan material, I think we only received 3mm fluid specimen, which is just 2 scans, so we don't need to drive up cell crazy to just call these positive upfront. So the next specimen again is a patient with primary lung adenocarcinoma. The cytospin specimen, there were only very scant atypical cells. I personally think the degree of TPI is not enough to just call it positive. It can be reactive because as you can see in the adjacent cells, this does not show like a big difference. So when you're dealing with a body fluid specimen, there's a lot of inflammatory cells like these. You should think about this can also be a reactive process. So I would say in this specimen, we only have very scant atypical cell. So this one is bigger than the other. So this one looks atypical. But if we only have one of these, it is very difficult for us to call it positive. But we do have quite some experience that the tumor cell can be very scant. Sometimes in the cytology preparation, it doesn't show clearly, but in the cell block preparation, it do catch a few like cluster of definite adenocarcinoma. So in the cell block preparation, I think we have very good confidence to call these adenocarcinoma. There were only like 2 or 3 clusters, so we call these positive. The patient has also been confirmed with adenocarcinoma previously with our cytology preparation. So this is compatible with like a persistent disease during the treatment. During the treatment, the disease burden can decrease. So this is possibly the scenario. The next specimen is a mediastinal lymph node aspiration. The specimen was obtained through endoscopic EUS guided biopsy. So it is a transesophagus aspiration. So it's a bit different from what we used to see, usually transstomach or transduodenum for the pancreatic lesion. This is the sampling of mediastinal lymph node. So in this specimen, we do see tight cluster of hyperchromatic cells. Some of the cell does shows this keratinization pattern. And if we can take a look of the more flattened area, we do see hyperchromasia, some coarse chromatin pattern. The cell does show like a spindling, so these overall looks like squamous cell carcinoma. The patient had a past history of larynx squamous cell carcinoma, so this is metastatic squamous cell carcinoma in the mediastinal lymph node. So mediastinal lymph node is particularly very difficult to sample. In the old time, you need to do an open chest surgery. Nowadays, you can do it via video assisted endoscopic through the pleural cavity, but you still need to collapse the lung, and the scope need to go to the mediastinum and to find the lymph node. Sometimes kind of tricky. And so with these endoscopic guided ultrasound, it is quite easy because there is only a very thin gap between the lymph node and the endoscope, which is the esophagus wall. So right beneath the esophageal wall, there's a lymph node, and you can sample, and you can like easily passing by larger vessel because you will have the Doppler to check where is the vessel. So this is a relatively easy procedure. The patient doesn't need to have like a general anesthesia, and it can be performed like within a couple hours, and the patient can just go home after that. So the next specimen is aspiration from the neck. The location is supraclavicle. So this is the head and neck aspiration, likely lymph node or soft tissue. So in this specimen, we see quite some atypical cell, and most of the cell actually arranged with these spindle morphology. The chromatin pattern, however, for these cells are mostly smashed. It does not show like clearly coarse chromatin. The chromatin pattern is like a smash pattern. So for these pleomorphic atypical cell with smash chromatin pattern, we will usually think about it could be a degenerative process instead of a real cancer. So again, we have some spindle cells, and in this focus, it is quite clear that there are some larger fat lobule, and these spindle cells are actually around these larger lobule. So it looks like a lipogenic adipocytic tumor, and with pleomorphic spindle cell. So if you put these two together, it is most likely to be a pleomorphic spindle cell lipoma of the head and neck. So it is relatively a small tumor by sonography, and this is pretty much what we have. I do a cell blood, but there is no residual like tissue over there. Because of the nuclear atypia and the scant like material that we have, I would still call these atypical. So we do see atypical cells, but I would address that our major differential diagnosis is the polymorphic spindle cell lipoma of the head and neck. So the next specimen is labeled as a thyroid aspiration. So on low power, we do see larger fragment of cells. In the background, we don't see any colloid. And we start to see some architectural pattern. In this area, we do see the larger fragment arranged in like a branching or a stack home pattern. Some of the cell does have prominent oncocytic chain, so these looks like oncocyte. If it is a thyroid, it looks like a Herzl cell. But because there is limited like a no colloid in the background, and the cell morphology is actually not typical for the follicular cells. You see very frequent naked nucleus in the background. So now we have more experience on this one. When we see something like this, no colloid in the background, plenty of the cells, and we see prominent like a papillary stachon pattern. Sometimes these cells can present as oncocytic, mimicking Hurso cell tumor. We need to think about, could it be a parathyroid lesion instead of a Hurso cell tumor? So when we check the past history of the patient does have chronic kidney disease. So in this sense, it is highly likely to develop secondary parathyroid hyperplasia. So we use the residual liquid-based preparation, and we do a cytospin, and we stain for GATA3. So this is diffusely positive for GATA3. So this is parathyroid nodule, can be a tumor, can be hyperplasia, most likely hyperplasia if the patient has chronic kidney disease, mimicking clinically a thyroid nodule, a thyroid tumor. We were able to correctly diagnose it as a parathyroid lesion instead of a thyroid like Hurso cell tumor. So the final specimen is from aspiration of the internal memory chain. So the patient does have past history of breast cancer, ductal carcinoma. So they are ruling out the recurrence of metastatic ductal carcinoma in the internal memory chain lymph node. So in this case, it does show cluster of hyperchromatic cells. Looks a little bit squamoid because you does see a little bit spindle cell in the background. So the breast ductal carcinoma is the most easily like a cancer to be mistaken as squamous cell carcinoma because it shows the squamoid morphology, hyperchromasia. So this is very common. So this is compatible with breast ductal carcinoma. And we does see there are some lymphocyte, crashed lymphocyte. We does see lymphocyte in the background. So this is from the lymph node. So this is metastatic ductal carcinoma. Okay, that is all the case for today. Thank you.